It's quite a wide topic, and I've been told I can keep talking without stopping, which is amazing. Sometimes it's difficult for me to stop when I start. So I'll cover three aspects. One is prediction of preeclampsia, and then I'll cover small babies and then preterm birth. And in relation to prediction of preeclampsia, I want to reference this slide, and I'm sure almost all of you have seen this slide before. But then it is very important for me to reference this because it just shows what we have, and it's essentially based on two recommendations, one from the United Kingdom, one from the America. And then it's recommending that if a woman has one high risk factor or that she has two or more moderate risk factors, then she's considered high risk and is recommended to take aspirin 75 or 81 milligrams from 12 weeks till the birth of the baby. The trouble is, although the method is simple, it's simple for you to use, but it's not very effective because you can see that for the prediction of term preeclampsia, the detection rate is only 30%, and for the prediction of preterm preeclampsia is around 39%. So we are really missing a vast majority of cases who could be benefiting from aspirin prophylaxis in the prevention of preeclampsia. Another issue in relation to this very basic approach to screening is that the adoption is relatively poor. Based on this study that we conducted in London, we learned that only 23% of high-risk women classified by NICE were taking aspirin. So it seems that women are very intelligent. They want something much more than a checklist-based approach in relation to the prediction of preeclampsia. We need to give them a personalized risk for the prediction of preeclampsia in order to drive uptake into aspirin prophylaxis. So over the years, we know that we need to improve the method of screening for preeclampsia. And now we advocate for the use of this competing risk approach, which has the advantage of allowing assessment of individual patient-specific risks of preeclampsia that requires delivery before a specified gestation. In addition, the use of Bayes' theorem to combine maternal factors and a series of biomarkers provides a natural framework for dynamic prediction in which risk assessment is updated as new information becomes available during pregnancy. What this slide means is that we have assumed that all pregnant women were to remain pregnant forever, that all of them would have preeclampsia. But whether preeclampsia occurs or not depends on whether delivery occurs before or after preeclampsia occurs. So it's a competing process. That's why we call it a competing risk approach. It's the same analogy for prostate cancer in men. So if all men were to live forever, they will all have prostate cancer. But whether it happens or not depends on whether they die before that or after. So this approach allows us to add in new biomarkers as new information becomes available, and also we don't need to generate a new model as we add on new novel biomarkers. And it takes into account the increasing effect of biomarkers with severity of preeclampsia. What do I mean by that? If you refer to the scatter plot, is that you can see these are the dots belonging to women with preeclampsia. And there's a negative correlation between mean arterial pressure, which is gestational age at delivery, meaning that the higher the mean arterial pressure, the higher the blood pressure, the higher the uterine artery Doppler, the higher the chance of severe early onset preeclampsia with delivery preterm. And that can be incorporated within our risk calculation. I don't want to bore you with a statistic, but then it is important for you to have an understanding, but I cannot do the maths. Just to remind you, I don't worry about the maths, but it's the concept that really matters. And because with this concept, we are able to add on an additional 10% detection rate to the prediction model. And by simply combining all the maternal factors and the biomarkers, we will reduce the detection rate. But by using the competing risk approach, we add on another 10% detection rate. So essentially, we have the base model with maternal factors, and we add on essentially 3 biomarkers for the prediction of preeclampsia. One is the measurement of blood pressure. I know you are at ultrasound conference, but I hope you go back and say to your colleagues is that they need to measure blood pressure accurately as well as you do ultrasound, because I do recognize that blood pressure might not be the most exciting part of pregnancy care, but this is what I did for 3-4 years, just for you to know. Day in, day out, I measure blood pressure. And so we have developed this protocol based on a database of 25,000 pregnant women. And this is the protocol. And we recommend the use of validated automated devices. And women obviously should be rested and make sure the arms are well supported at the level of the heart, not too high, not too low, and using the right size cuff, because all of these little things would influence the measurement of blood pressure. And blood pressure has a very tight standard deviation. So the slightest error in the measurement protocol would then cause a massive difference in the screening performance, okay? And we recommend using measurements from both arms to be taken simultaneously, and then once and twice. So altogether, you have 4 sets of measurements for the risk calculation. And then I do have a video, and then you're more than welcome to scan the QR code here for a longer version of this, essentially just to show you that it doesn't take more than 2 minutes in your clinical setting. And the machines are about 20 USD. So they're not expensive. They are validated for use in pregnancy, making sure, okay, we have 2 people doing the blood pressure, but essentially I can have 1 person doing the blood pressure measurement, putting on the 2 cuffs and pressing it once and twice. It takes no more than 2 minutes. And the reason being is that you will recognize the interim differences between the blood pressure. And that is important for us to account for. And the first set of measurements, just for you to remember, are not predictive of preeclampsia. Somehow, women are very anxious, and the first set of measurements are usually a bit higher, and that doesn't allow you to predict preeclampsia effectively. So you must take a second measurement, okay? So essentially, for the second biomarker is an ultrasound marker. And we advocate for the use of ultrasound, transabdominal ultrasound. The most important tips I want to give you is to identify the anatomy. You must be able to visualize the bladder, the uterus, and the cervix, and then fixing the transducer in the midline, and then gently tilting the transducer to the side of the cervix, and use color flow mapping to identify the uterine arteries at the level of the internal os. Please remember, the cervix is small, not massive, okay? So your movements must be quite gentle and not massive, okay? Because the moment you move your probe the transducer very fast, you will for sure miss this vessel that is just sitting by the sides of the cervix. And then this is the moment when you can be a little bit slow, then to be fast, because then you can wait for the color Doppler signal to turn on, because not all of you would have an E10 or a Samsung W10. And if you have a low grade or middle grade ultrasound device, the Doppler signal will take some time for it to show up, okay? So take your time, and then you'll be faster. And then you need to use sampling gate of 2 millimeters to cover whole vessel, and ensuring the angle of inclination of less than 30 degrees. Then, and also the peak systolic velocity is more than 60 centimeters per second. And that is essentially the 5th percentile of the PSV. It doesn't tell you that you're definitely measuring the uterine artery Doppler, but it tells you that you're likely to be measuring the uterine artery Doppler. So you must follow the steps I've shared with you. And then take a left and right PI and take an average of the 2. Again, I have a video here. You can scan the QR code for a longer version. And within that version, I also cover an alternative technique if you get into trouble that you cannot identify the uterine arteries by the conventional sagittal approach, and you can attempt a transverse approach. But I do not want you to replace the sagittal approach with a transverse approach, because all the data that have been utilized for the development of the prediction model is based on a sagittal approach. And again, very simple, as I mentioned, identify the anatomy, fixing the transducer in the midline, and then tilting the probe gently to the sides of the cervix. Using color flow mapping, you'll be able to visualize the uterine artery at the level of the internal os. Then that's very simple. And I don't think that's anything difficult, because you're not talking about a moving fetus here. But you do need to really be quite meticulous about identification of the anatomy. So essentially the first trimester combined test, including maternal factors, mean arterial pressure, serum placental growth factor uterine artery Doppler, can achieve detection rates of 90% at a 10% false positive rate for early onset preeclampsia, and for preterm and term preeclampsia, the detection rates are a little bit less, at 80% and 45% respectively. And then, although I would say that the model achieves a slightly lower detection rate for preterm preeclampsia, but we have really good data to suggest that it's sufficient for us to apply aspirin prophylaxis in the prevention of preterm preeclampsia. And then, just to show you that how well the addition of biomarkers perform in comparison to a checklist-based history approach, we are able to double the detection rate at the same false positive rate. So I think this is particularly true for Asia, and I'll show you the data in a subsequent slide. So just to let you know about the number needed to screen, because you often ask me, well, what is the number needed to screen? Is it worthwhile implementing screening? And it is an approach to measure screening benefit. And according to the Aspirate data, the number needed to screen to prevent one case of all preterm and early preeclampsia are 143, 250, and 400 respectively. And just to compare with the number needed to screen for preventing one case of early infection due to GBS through universal screening at 35 to 37 weeks of gestation. And on the side, on the left-hand side, you compared with the number needed to screen for the prevention of cancer. And for me, it's an absolutely no-brainer that you must provide effective screening in the first trimester of pregnancy, and that you must add on biomarker to the method of screening. And some of you would have seen these results when I returned to Asia. That was in 2017. We embarked on a validation study, including more than 10,000 cases, and we do have cases from Vietnam as well. And we concluded that fixing the false positive rate of 10% and 20%, actually the screening performance between the Asian data and the FMF data are very comparable. Yep, as you can see, as shown in this diagram here, achieving around 62% detection rate at a 10% false positive rate and 20% false positive rate for 75% false positive rate. And in comparison to NICE and ACOG, if you're still obsessed with sticking with the checklist-based approach because it's cheaper, it's easier, but obviously I've shown you the problem. Yes, uptake of aspirin prophylaxis is low because it's not a very sophisticated approach to screening. And in Asia, please be reminded that our women are thinner, are younger, with fewer comorbidities. So if you apply the UK and the US-based approach to screening, then you will achieve a much lower detection rate in comparison to the triple test, including the 3 biomarkers as I have presented to you. So when I compared the FMF triple test with ACOG, and you can see that the confidence interval of the detection rates did not cross between the 2 methods, and same applies to comparing the triple test against NICE. So remember, in Asia, our populations are different. And if you don't add on biomarkers, you are really performing quite poorly for the prediction of preeclampsia. So in 2019, actually around the same year, ISWOC also endorsed our screen and prevent approach. And here I'm quoting the FIGO guidelines, and you can scan the QR code to have direct access to the FMF calculator. We need to measure the biomarkers and convert them into multiples of obedience, accounting for confounding factors, including ethnicity, previous history of preeclampsia, and so forth. And then we use a risk calculator to generate the risk. A woman is considered high risk when the risk is 1 in 100 or more, based on the combined test. Unfortunately, the model is better for preterm preeclampsia, not for term preeclampsia, and certainly we need to continue our work for improving the prediction for term preeclampsia. So prevention of preeclampsia, and I'm sure, again, almost all of you would have come across the Aspirate trial, but a gentle reminder that we did this study in nearly 27,000 singleton pregnancies. And we randomized 1,600 women, high-risk women, into either aspirin or placebo, and we demonstrated that we were able to reduce the rate of early onset preeclampsia by 80% and 60% reduction in preterm preeclampsia with the use of aspirin, 150 milligrams, given nightly from 11 to 14 weeks till 36 weeks gestation. And this is really to show you that we were able to identify the right group of patients that benefited from aspirin prophylaxis at the right dosage, given at the right time. So if you were to deviate from this, then I cannot guarantee you would achieve the same treatment effect size from aspirin prophylaxis. What is important is acknowledging the importance of drug compliance. Here we can show you that if a woman has very good compliance, exceeding 90% or more of the aspirin tablets, we could even reduce the rate of preterm preeclampsia up to 67%. And in high-risk women without chronic hypertension and a high level of compliance could actually even achieve 90% reduction in the rate of preterm preeclampsia. So this is a very important message for our high-risk women, that drug compliance is essential. And also we were able to reduce the cumulative length of stay in the NICU. And I'm sure you all agree with me that preterm birth is a terrible outcome for the babies, and there's a high chance of death or disabilities. Yeah, and then in the long term, also has an impact on work capacity. So the impact of what you do during pregnancy is lifelong for the baby. If we are able to predict and prevent preterm preeclampsia, then we'll be able to also reduce preterm birth. And preeclampsia is one of the leading causes of preterm birth. So with a fecal recommendation, and here we state that for high-risk women, we should commence aspirin prophylaxis at 11 to 14 weeks at a dosage of about 150 milligrams to be taken every night until 36 weeks of gestation. And aspirin should not be given to all pregnant women. And I just want to share with you our real-life data from my unit. And is quite a painful process, but we were able to implement the Screen and Prevent program since 2020. This is the data I think we must have screened at least 10,000 cases, but now I'm just showing you some data just to show you that amongst the 7,200 women screened, the low-risk women had very, very low rates of early onset preeclampsia and preterm preeclampsia, 0.04% and 0.2%. So this is extremely reassuring. And amongst the high-risk patients, sadly, some women declined aspirin prophylaxis, and amongst those, actually, the rate of early onset preeclampsia and preterm preeclampsia are 77 and 35 folds increased in comparison to the low-risk cases. So this is a very dramatic increase in comparison to the low-risk group. And for those who took aspirin, we were able to see a trend of reduction of 50% for early onset preeclampsia and 30% for preterm preeclampsia. So these are unpublished data, and my student, PhD student, and Long is in the back, and he's working super hard to close this data set so that we can publish these data this year. And of course, we wouldn't have been able to succeed with this study without the collaboration of all our friends, including friends from Vietnam. So moving forward, I want to touch on small babies. So without doing anything else, we combine maternal factors, measurement of uterine artery Doppler, placental growth factor, and arterial pressure as per the screening protocol for preeclampsia. We are able to achieve a detection rate of 56% for SGA less than 10 percentile with delivery before 32 weeks, and 46% detection rate for SGA less than 10 percentile with delivery before 37 weeks. So this is a collateral benefit that you would gain from our prediction model. It just shows that, yes, we have focused very much on prediction of preeclampsia, but it is also a tool for assessing placental health. We are able to predict for preeclampsia we're also able to predict for small babies and without doing anything else. Same protocol, and you are able to achieve some prediction. And then recent development for the prediction of SGA involves the development of a competing risk model by maternal factors and biomarkers at 11-13 weeks. And this approach involves a joint prior distribution of gestational age at delivery and birth weight Z-score, updated by the biomarkers likelihood according to Bayes' theorem. The pattern of change conditioned to gestational age at delivery and birth weight Z-score is similar for all biomarkers and is captured by the same folded plane regression modeling. It's too fancy here on the left, you can, based on these diagrams. And the best biophysical predictor of preterm SGA was uterine artery Doppler, and the best biochemical marker was placental growth factor. And the prediction of SGA was consistently better for increasing degree of prematurity, greater severity of smallness, coexistence of preeclampsia and maternal, and an increasing number of biomarkers. The combination of maternal factors with all biomarkers predicted 34%, 48%, and 59% of all cases of SGA with birth weight below the 10th percentile, with delivery at beyond 37 weeks, less than 37 weeks, and less than 32 weeks, at a 10% false positive rate, respectively. And then the respective values for birth weight less than 3rd percentile were 40%, 53%, and 64%. And obviously the worst outcome you can get is small babies with less than 3rd percentile birth weight together with preeclampsia. Then we were able to achieve the respective detection rates of 46%, 67%, and 80%. So we're really killing two birds with one stone, one approach for two outcomes of interest. So we were also interested to look at prevention of small babies with the use of aspirin prophylaxis. So I think these graphs are very complicated, but then ultimately what it really shows is that the use of aspirin were able to prevent small babies, in particular those with preeclampsia. So when the two conditions coexist, of course, we get the best result with the use of aspirin. But actually dropping preeclampsia aside, we were able to actually even benefit from the use of aspirin for the prevention of pure SGA. And you can see this here. And so this is combined reduction of 73% of SGA on top of preeclampsia, and then for very preterm SGA less than 10 percentile, and 40% for preterm SGA as well. And all in all, we've estimated that just looking at pure preterm and early SGA, then we were able to prevent by 20% and 40% respectively. So I think it is important for us to conduct prediction of preeclampsia and to benefit from the collateral advantage by also predicting and preventing SGA. And in terms of the number needed to prevent, I'm combining the data for both preeclampsia and SGA. You can see that the number needed to treat to prevent one case of preterm preeclampsia. We need to treat 38 high-risk cases, so this is a very respectable number. So anything less than 100 is considered to be very good. And for early onset preeclampsia, the number needed to treat increases to 69, but still very respectable. And for preventing small babies, the number needed to treat ranges from 16 to 30. And for preventing stillbirth or neonatal death, the number needed to treat is 34. So I think I'm closing this placental complication story with preeclampsia and SGA, just so my final slides are relating to preterm birth. Here I show you this very well-known slide, I think, is that the use of cervical length assessment at 20 to 24 weeks is essentially the only reliable tool that we have for the prediction of spontaneous preterm birth. And actually the detection rates are not even that great, as you can see, but by fixing a cutoff of 25 millimeters or less, that gives rise to a screen positive rate of 7%, achieving a detection rate of 38%. But once you combine with a prior history of preterm birth, then you can see we can increase the detection rate to 80% for the prediction of extreme spontaneous prematurity before 28 weeks. And the detection rate goes down to around 60% if we're targeting spontaneous preterm birth between 28 to 30 weeks. And for delivery between 31 to 33 weeks, the detection rate is around 55%. Nonetheless, this is what we have. What we have learned is that the use of vaginal progesterone at mid-gestation is effective in the prevention of spontaneous preterm birth amongst those with a short cervix. However, amongst those with a very, very short cervix, less than 10 millimeters at mid-gestation, actually progesterone isn't so preventative. So the question we have raised is that, are we catching this cervical shortening too late? Should we have screened for this group of women at an earlier time point? Could we have moved the screening time point forward to the 11 to 13 weeks time point? Because that is the key visit for Down syndrome screening, aneuploidy screening, preeclampsia screening, SGA screening, so forth. So many years ago, actually, that was more than 12 years ago, we already looked at this in London. We have established that indeed at 11, 13 weeks for women who will subsequently deliver preterm spontaneously, the cervical length is already shorter. However, there's quite a significant overlap between the term births, as shown by the blue bars, as compared to the spontaneous preterm birth group represented by the red bars. And the combination of maternal factors and cervical length can only achieve 45% detection rate for spontaneous preterm birth before 34 weeks. And we added a biochemical marker, alpha fetal protein, and we were able to achieve a detection rate of 50%. I mean, we got stuck at this, but we continued our work. When I moved to Hong Kong, very interested to see whether actually in Asian women we could potentially introduce a cervical screening program at 11, 13 weeks. What we found is that actually cervical length, the cervix amongst Chinese, East Asian women is a little bit different from what I have observed in the UK. The cervix is almost always curved. So I'm sure you're familiar with the fact that the protocol that we have for the measurement of cervical length at mid-gestation is that we take a straight line from the external os to the internal os. But in our setting in Asia, this is impossible because we would be under measuring the cervical length, which means that we are not able to differentiate a true short cervix from a normal length cervix because the cervix is always curved. And therefore, we embarked on the study to look at the two methods, single line method versus two line method. And the conclusion, to cut the long story short, is that indeed, once we started measuring the cervix by a two line method, you might ask me, why don't I use a tracing method? I'm afraid tracing method takes a little bit longer, and people complain to me that to do a cervical length assessment, it involves a woman going to the toilet and dressing. It takes an extra 10 minutes. I remember being challenged that to measure cervical length is too onerous and therefore it's not worthwhile. So obviously from my perspective is to provide a pragmatic approach to screening, and therefore we adopted a single line method versus a two line method to make it more efficient. And we concluded that indeed a two line method is more predictive of spontaneous preterm birth in comparison to a one line method, a single line method. But then still the area under the curve is suboptimal, 0.6. So then we also looked at other parameters, including elastography. Elastography essentially tells you how soft, how stiff the cervix is. And the conclusion is that indeed, even at that time point, 11, 13 weeks, women who are destined to deliver preterm spontaneously, they have a softer cervix at that time point. And if we go for a soft cervix with a elastography score less than 10 percentile, is associated with a 2 and 7 times fold increase in the risk of preterm birth. So obviously, hopefully with more data and in a prospective study, we'll be able to see whether the clinical utility of this tool could be demonstrated. Another thing that, because obviously I got obsessed with this curvature of the cervix, and so one of my other PhD students embarked on looking at the different cervical angles, and in the end, we developed 8 angles. Because the trouble we have at this time point, at this 11-13 weeks visit, is that we have the isthmus, and therefore we had to create an extra line to look at the 8 different angles. So this is unpublished work, and we were fascinated because we were able to see that a narrower angle between the posterior uterine wall and the cervix may be associated with an increased risk of spontaneous preterm birth, but not a significant predictor after correction for cervical length and uterine position. So because we had to take into account whether it's a retroverted uterus or anteverted uterus, as well as the fact that we have measured the cervical length. So possible reason may be related to is reflection for the position of the cervix, which is a component of the Bishop score. The narrower the angle, the more anterior the cervix, which is easier for the delivery. So I want to close this talk, just a reminder that we really should bring forward a comprehensive risk assessment to the 11-13 weeks scan, whereby you'll be able to screen for a wide range of pregnancy complications and even placenta accreta spectrum disorder, because that is really the time point you need to look out for suspected PAS, and that will be covered in my talk tomorrow as well. And then that will then allow you to triage women into different care pathways and make plans and utilize healthcare resources more intelligently.